BioHorizons came out with another 3mm implant, and then the next sort of major change of 3mm implant was the Zimmer Unipost. Dr. Salama actually helped in the design process in this, and what this implant brought to the market was a contoured abutment that basically mimicked a relatively ideal CEJ to the clinical crown. This was a relatively challenging patient. She'd been in orthodontic care for over 5 years for different reasons. She still had an anterior open bite. The teeth had been facial displaced significantly, and they were hoping to end up restoring the congenitally missing laterals and possibly some of the mandibular lost teeth. When we ended up looking at our CT scan, and these are just the original radiographic findings, you can end up looking at some of the spaces that were missing. But again, when you start looking at the CT scans, you start looking at some of the potential challenges. First of all, in the maxillary laterals, it's not that dissimilar to what you've seen earlier. You've got about 5 millimeters of interproximal bone between the cuspids and the centrals, and you've got this concavity on the facial, which is going to somewhat complicate things, but can still be handled by manipulating the bone. The CT allows us to place some template implants in there and look at the relationship of insertion, these implant trajectory as it relates to the adjacent, teeth. One of the clinical challenges or incidental findings that we discovered when evaluating the possible surgical sites for dental implants was the relationship of the natural teeth, especially in the maxillary anterior. And you can end up seeing where some of these teeth following orthodontic teeth movement had been somewhat displaced, where there was minimal facial bone. So the first thing we needed to end up doing was reestablish a more healthy tooth positioning so that these teeth had a better prognosis. What was elected to be done was to bring back the mandibular anterior, teeth, try to close the space up in the maxillary, in the mandibular anterior, and place in an implant, and just address the maxillary lost laterals. And you can end up seeing that when we end up doing our space analysis, here, and trying to work out different, clinical scenarios, there really wasn't an ideal situation to end up restoring the mandibular anteriors with dental implants. So again, our best bet was to try to close the spaces, bring the teeth back so as to decrease their facial flare, and if we had some spacing issues, we could end up addressing those with crowns. Our focus was going to end up being, again, on the maxillary lateral spaces. Again, in these situations, you want to do everything you can to enhance the healing process. In this situation, we're going to end up, again, using some PRP, and we're going to end up placing that around our flaps to enhance the revascularization and hopefully have as little bone dieback as possible. Again, there's other physiologic enhancing methods that can be utilized, but we want to do everything we can to end up helping the body in its attempt to, if not regenerate, at least maintain what you've got. This is the patient's condition at the time that we are going to initiate treatment. You can see that we're trying to bring back the mandibular teeth, and the maxillary arch is pretty stable. This is basically as good as it's going to get. We cannot constrict this anymore, nor can we afford to expand anymore with fear of pushing these the roots beyond the facial plate. So what we're going to end up doing is we're going to make an intersulcular incision and then make a lingual incision across, and then another intersulcular incision. And then after we end up making these incisions, we will end up reflecting the tissue to the facial using a Molt curette. All we're going to do is expose the crustal bone. We're going to do very little reflection. We're not going to do any reflection on the lingual, and we're going to do very little reflection, on the buccal. In certain situations, we're going to place a narrow implant and do some guided bone regeneration. I will end up expanding my reflection further on there. We'll do some bone and a barrier, but we do not make any type of papilla-saving incisions. Once the crustal bone has been exposed, we use our initial pilot drill, which is a very sharp cutting drill going right through the cortical plate. We got an idea as to what our implant trajectory is going to end up being. You want to keep between the two cortical plates. In this situation, you can see that we stayed within the confines of the orthodontic bracket, and here's our trial insert. It's going to be, as it comes out, it's in between the bone, and it is going to be parallel with the incisal edge. Ideally, I'd like to have it slightly lingual. You'll see later on that it will have some clinical, implications. Once we've ended up going with our pilot drill, we're going to expand the osteotomy using osteotome. As you go deeper, you can see that the trajectory is going to come out more towards the facial. We will tap the osteotome, and as it gets to full depth, we can start putting some pressure towards the lingual so that the final trajectory is going to be more towards the lingual. The osteotomy is expanded to a 2/7, which will still allow for a final osteotomy to be of smaller diameter than our implant, so we should end up having some fairly good initial stabilization. Note that the bone spreader is still facial, as compared to the adjacent teeth, or slightly facial. And once we have finished it, then we can end up placing, if you can see it, you can see how as we're rotating, we're putting some lingual, pressure slightly. We just, move it out. That final preparation is going to be pretty close to what you would expect your final trajectory of your implant to end up being. Now, here's the 3 millimeter unipost. We're going to end up placing a little platelet-rich plasma within, our osteotomy. Maybe a little bit facial. You can place a little bit of the PRP on the surface of the implant itself. And then we're going to drive the implant into our osteotomy using a sort of linear driver. This linear driver does lend itself towards helping with the alignment process or the insertion of our final implants. You can see the implants going in place. Once we've done that and we end up angling it properly, then we're going to end up addressing the number 10 site. Now, I'll just suggest when you look at the area number 10, the area is actually thinner and the trajectory is a bit more radical. One of the nice things about the Unipost implant was that not only did it have a straight abutment, but it was also designed with an angled abutment. This angled abutment lends itself to insertion in the bone where you maybe had a more divergent trajectory. So when we place the implant in this other side, we're going to end up, following basically the same reflection protocol that I described earlier, but we're going to end up placing a unipost angled abutment, so that the final abutment is going to, in fact, be more ideally positioned as it relates to the adjacent teeth, and thus make our prosthetic options a bit more reasonable. So you can see that we did minimal reflection primarily just to expose the crustal bone. Our analysis of trajectory was based on CT. We're using references of the adjacent teeth, the orthodontic wires. We're not using a surgical guide. Here we place our initial osteotomy, our trial insert. And the trial insert, you can see that the trial insert is guided a bit towards the cuspid. When we end up expanding the osteotomy, we can correct that using a different burr or, in this situation, a bone spreader. We're just pushing it towards the cuspid so that we can enhance the trajectory and circumvent, the roots. The nice thing about using bone spreaders, here's a 2.7 millimeter that's going to be our final osteotomy, is you're less likely to end up injuring the root as compared to using a regular burr. So here we're spreading, and you'll note that it's still going to be slightly more facial than what is ideal. Placing our PRP, and this is a angled head implant. The carrier for it allows you to insert it or press or rotate in a linear direction, but the final abutment has a 15-degree angle. Once the implants are inserted, you can end up putting your provisional crowns. In this situation, we ended up using some of the original crowns that had been bonded to the orthodontic brackets, and we rebonded the provisional crowns to the orthodontic brackets. Here you could end up seeing, after a bit more soft tissue healing, the soft tissue scallop effect around the implants that was created using the provisional crowns. Now, at the time of prosthetic preparation, you notice that the implants are still somewhat more facial than ideally desired. So they have to end up being reduced. The Zimmer implant, like a lot of the newer implants, does allow for a one-piece implant analog. And what we do is we end up pouring the models up using this one-piece implant analog, and we reduce that, on the models, and we create a reducing jig that the implant can end up being modified consistent with what you do on your working models in the mouth. So we make our final crown on the modified abutment, because to pour this up as a die would be challenges relatively thin, and we take it back to the mouth, and with copious irrigation, you can end up reducing the abutment. And you can end up seeing here that you've got an emergence profile that lends for the support of the soft tissue and goes to the margins. These are the final restorations being put in place. Now, since the Zimmer implant was developed, 510K has allowed for numerous, almost every major implant system has a a one-piece 3 millimeter, implant. I'll show one last one that, how we put the surgery and how it's restored. This is a similar case to what you showed before. In this situation, you can end up seeing that the provisional teeth on the orthodontics are relatively large. You can see the original orthodontic space. The spacing between the adjacent teeth is only 5 millimeters, as we described. The 3D reconstruction showing sort of generic 3 millimeter implant shows that you need to end up optimizing trajectory. You can see in this situation, the root proximity becomes a bit more of a challenge. You've got less room to work with. Did our treatment planning, prosthetic, options. And the osteotomy, again, this is almost exactly what we described before: intersulcular incision towards the lingual, repositioning the flat to the fascia to expose the crustal bone. In this situation, we've got a spade drill that is very, very sharp, and it's very much like the pilot drill that we described before. And you end up going through the cortical plate, going into the medullary bone, and then we use a very thin osteotome to end up creating our initial osteotomy between the two cortical plates within the medullary bone. And by putting pressure, slightly lingual pressure, we're able to not only expand the bone towards the facial, but you can actually torque the osteotome in such a way that you actually can enhance your lingual positioning. And this can be further enhanced when we go to a 2.7 millimeter implant. By doing our osteotomy using osteotomes as compared to burrs, you'll get some recoiling back of the bone. You end up losing virtually no bone in the process, and you get the best stability of your initial stability of your 3 millimeter implant. Again, once this is done, you can see that there's been minimal reflection on the facial. You can check to make sure there's no perforations with your perio probe. And then the implant is inserted using a vertical driver. In this situation, you can see that the implants, even though we've made all efforts to position it lingual, once it's within the confines of the orthodontic bracket, but it's still somewhat facially displaced. There's a snap cap or a healing abutment or a temporary cap that snaps right over the implant, and you can end up fabricating your provisional crowns at the time of surgery without any reduction of the implant if it's ideally positioned. Again, the same osteotomy is prepared on the other side and the same methodology, similar methodology. And then the implant is inserted. It's first inserted by hand and then using a vertical driver. You can end up seeing the relationship of the implant as it compares to the adjacent teeth. It's within the confines of the orthodontic wire, but still somewhat facially displaced. We reposition the tissue again towards the facial, and we use this healing or this provisional button that snaps on to start tending the soft tissue. You can put a provisional crown in place and finish the margins to the margins designed for the implant. This is the operative report right after surgery. This is the post-operative Panorex. And here is the soft tissue, after soft tissue healing. You can see this is a hollowed out abutment. If you were to prepare this in the mouth, it would be very difficult to get an appropriate die fabricated. It's very difficult to get an impression of a narrow implant. So what we do is we take a snap cap impression. This snap cap is designed to fit right on the abutment. We pull that in our impression, and we create working dies that we can end up modifying, at the time of lab, and fabricate our prosthetic or our final crowns on these modified working dies. Once the crowns and dies have been modified or make provisional crowns, we can go to the mouth, use our reduction jigs, and modify the abutments in the same fashion that we did our working dies. Did the right one, the left one, we put our temporary crown, on, and we end going to final crown, or you could end up creating some new provisional crowns while you modify or you fabricate your final crown based on the abutments. These are temporary crowns. We in this situation, we elected to make some new provisional crowns with the new abutments, the new contoured abutments, to try to create a little better soft tissue contour, increase our biotype a tad. And then these are again our temporary crowns. Once the temporary crowns are done, you can end up seeing that the the scalloped effect around the implant has been enhanced, your biotype's improved a tad, and then it's just a matter of fabricating new crowns based on the dies that we've already have established. These are our new crowns. You can end up seeing the emergence profile is going to end up being consistent with what we desire. These are final abutments in place, and then the crowns are being inserted. These are the crowns right at the time of initial insertion. Okay, so thank you for listening to me, and I hope I gave you a few new insights on utilizing narrow implants in the aesthetic zone. Thank you.